Hello and welcome everyone. Thank you so much for joining us today. I'm Jessica Rodriguez, Director of Product Introduction Access at AVAC. I see that many of you are still joining, so we'll give it a few more minutes just to achieve critical mass. And as we wait, we really want to make the webinar very interactive and engaging. So as you wait, we have a few questions for you, through poll questions for you to perhaps answer. Would be great if you can respond and really to get a sense of your interest and where you're joining us from. And then second, please, feel free to put in the chat who you are and what organization you work for and where you are based. And we'll get started in just a moment. Great, and now the poll is showing, so please take a moment to fill out the poll. We really want to assess, where you see integration, where you live and work, and another question about providing PrEP and family planning clinics, and is it your view that it would increase uptake among women? So thank you and welcome everyone. I see many of you are including your name and organization and where you're from in the chat. And as you fill out the poll, I wanted to just provide some background on why we're here today, and want to say it's really a pleasure to be hosting this webinar on new insights on integration of HIV prevention and sexual and reproductive health services. And it's an honor to welcome you all on behalf of AVAC and our partners, the Ministries of Health in Kenya, Malawi, and Zimbabwe, as well as Pangea Zimbabwe AIDS Trust, or PZAT, and Georgetown University's Center for Innovation in Global Health, as well as many of the advocates that AVAC works closely with. And the call for integrated HIV and SRH services is not new, and for the prevention field, the need for women-centered care and integrated services was certainly amplified by the ECHO trial results, which showed high HIV incidence among women in the study. WHO and national guidelines on integration exist and have been recently updated, but many of these policies preceded the availability of ARV-based prevention. And policies, often when in place, have not consistently translated into integrated care for women. And this webinar will take a look on how to build on longstanding policy and advocacy to build on those efforts to really see and realize the promise of integrated services in practice. In 2019 and 2020, with support from the Bill and Melinda Gates Foundation, AVAC collaborated with Ministries of Health in Kenya and Zimbabwe, and likewise Georgetown University's Center for Innovation in Global Health collaborated with the Ministry of Health in Malawi to assess the greatest barriers to HIV SRH integration and to identify promising approaches that could help overcome them. These assessments generated concrete recommendations on how to more effectively reach adolescent girls and young women in particular with integrated HIV prevention and SRH services, including expanding access to existing and future pre-exposure prophylaxis products. And more details on the findings from these assessments can be found in a manuscript that was recently published on Gates Open Research, and which we will be sharing with you. So it is our hope that the findings and lessons from Kenya, Malawi, and Zimbabwe can be applied across countries and settings and spur further investment and integration. And each of our esteemed presenters will focus on unique aspects of integration based on their context. So there will be 3 consecutive presentations, and we encourage the audience to submit questions in the chat as we go, and these questions will be answered during the Q&A and the panel discussion. So before I turn it over to our first presenter, I just wanted to get a sense of perhaps we could close the poll and see the results of the poll. So I think the vast majority, almost 60%, 57% of all of you said that rated your country a 3, so sort of average in terms of making progress toward integration. So I think that's very, very encouraging, and happy for all of you to comment. And so, wow, it's almost near universal that almost all of you said that providing PrEP and family planning clinics would increase uptake of PrEP among women. And so there certainly is a sentiment that integrated services could make a difference for the health outcomes of women, and that's really exciting to see, and we will explore that in this webinar. And so without further ado, I'm going to introduce our first presenter, Ruth Kamau, who currently works with the National AIDS and STI Control Program at the Ministry of Health in Kenya as a program officer supporting the rollout of pre-exposure prophylaxis. She's an experienced clinician with many years of experience working in both the public and private sector, and she will be discussing moving from policy to practice, how Kenya's HIV SRH integration subcommittee is shaping a national process on integration. Over to you, Ruth. Oh, I'm not sure that, can we hear Ruth?
No, I can't hear Ruth.
I can't hear, okay. Ruth, we're having trouble hearing you. Ruth, can you test once again?
Sorry, there was a device hitch.
Okay.
We can start.
Yes, now we can hear you and see you clearly. Thank you.
Okay, so I'll be discussing the role of the HIV SRH Integration Subcommittee in shaping the national process of integration. Next. So our background is that Kenya has a rich policy environment supporting delivery of both SRH services and HIV services. But there is siloed programming. We have 2 divisions that are responsible for implementing these services. That is NASCOP and Division of Family Health. Women of reproductive age in Kenya have high HIV incidences and also unintended pregnancy. From our data, our prevalence rate is at 4.5 according to 2020 estimates, much higher in women who are at 5.8%. According to Kemfia 2018, about 23% of this new infection occur in AGAW. There was a 22% uptake of PrEP among HIV negative women who are accessing family planning services. And we have a 54% unmet need for family planning among sexually active AGAW. Next. This is a summary of our journey in the integration work. And in the subsequent slides, we'll be providing details of each of these steps that we have highlighted here. The journey began in October 2019 to around January 2020, when we conducted assessment in facilities to, we'll be seeing the objectives later. Then we had a dissemination meeting, disseminating the finding. And then in July 2020, there was establishment of the HIV SRH integration subcommittee. And in 2020, we conducted a policy review and developed some draft circular. Then in September 2020, we engaged the counties so that we can get more input from them. And in January, we had development of some key documents to support the rollout of integrated services. And in August, we kick-started our pilot of integrated services. Next. So the first step was the facility assessment, which was carried out by the Ministry of Health in partnership with EVAC, that is a PMM. And we conducted a rapid assessment that was part of a larger body of work focused on exploring expanded and alternative delivery of mechanism to promote uptake of integrated services. Our objectives was, one, to gain better understanding of the potential for integration of PrEP and other biomedical HIV prevention products and FP products, and to see if they have the potential of increasing access of both services. And the second objective was to identify pathways for engagement and implementation of different levels of the health systems. Where we did the assessment, we did it in 10 primary health facilities in different counties. We had a key informant interview with 40 MOH officials, and we had FGDs with AGYW. So we had 2 dialogues with AGYW. So our key findings from this assessment was, one, Kenya has a policy and a rich policy environment that supports integration. However, some of the policies are outdated and they need to be updated. And then our policies, most of them do not tell us how to go about the integration. And then number 2, there is need for strengthening and expanding youth-friendly services, along with delivery of PrEP to ensure that AGYW are receiving comprehensive package of services. Then there is need to raise awareness of PrEP among healthcare providers. And lastly, there is need to provide capacity building for service provider so that they can be knowledgeable to be able to offer the package of integrated services. Next. The next step was to disseminate the findings of the facility assessment, and we convened a dissemination meeting. This was convened jointly by NASCOP and Division of Family Health. The key objectives of this meeting was to share the assessment finding and also solicit feedback from the stakeholders who are attending the meeting. The stakeholders were both from the national and county level Ministry of Health officials, frontline service providers from the facilities that have been assessed. We had implementers, civil society organization, and donors. So from this meeting, our key deliverable was to develop an action-oriented, practical, and locally driven recommendation to catalyze HIV prevention and SRH integration and discuss the critical next steps. So the key recommendation from this engagement was that we form an integration subcommittee that will work, and the mandate of some of the key deliverables of this subcommittee was, one, to map out and compile and review and update the policies documents that were available, then develop a circular that will provide guidance to service provider on how to offer integrated services, then conduct utilization data analysis, and then pilot this integration and mobilize for resources. Next. Then we formed the integration subcommittee, and we had many proposed membership, both MOH, partners, private sector, donors, and civil society and AGYW representative. At the TOLs of this subcommittee, it was co-chaired by both divisions. So one was to conduct the systematic review of policies, and then check what is addressed in this policy, what is missing, and provide recommendation. Then develop an integration circular, and then develop accompanying rollout document to support integration. Next. We also disseminated the findings from the 2 previous activities to the county, and the objective of this engagement was only to disseminate the finding and also solicit inputs from the county officials on how best to carry out integration. Next. Concurrently, we analyzed our data that was available on the national reporting system so that we can understand better how to go about utilization, integration in selection of which service delivery points would work best, which counties would work best, would be ideal to start with. Next. And this is what we have been able to do so far. We have been able to develop key rollout document. We have been able to disseminate integration of the integration findings, and we have been able to conduct provider training. We decided to start with 5 pilot counties, and we have been able to train service provider. On conducting outreaches, we have not been able to do demand creation nationally, but we started at facility level by the healthcare provider during maybe using health talks. We have been able to review this training package for postpartum and post-abortion family planning. And then we have been able to develop the measurable metrics, and later upon completion of pilot, we shall include them in the national reporting system. We are improving quality and expanding in private sector. These quality standards have been developed and dissemination is ongoing. Next. Our key short plans, one is to continue with the pilot in the 5 counties and closely monitor the pilot through supervision. We shall have a midterm data review. We are still ensuring that we are strengthening our coordination mechanism at all levels, and there is ongoing policy dissemination, and then we shall begin documentation of the successes and challenges of the integration work. Then we have a policy document that our work is anchored on, that we have begun the process of reviewing. Next. Our longer term is that upon completion of successful pilot, we shall begin scale up tentatively in February 2022. We will embark on demand creation activities, and then we are reviewing our Kenya EMR to include the integration services, to include the indicators. Then we shall convene a national best practice sharing forum and conduct data and service quality audits. Next. So what can other countries learn from our experience? We did not start from zero because this guidance had been given by WHO, and we picked from there. So you don't have to begin from zero. You can review the policy documents that your country has developed and see from there what you can learn from them, what are the gaps and what needs to be done. And then drawing from the lessons from successes of other programs like PMTCT, see how you can apply this lesson for the success of integration. Then involvement and participation of all stakeholders at all levels. And then you can choose to go the pilot way. Instead of going national scale up, you can decide to pilot and then document the learnings. Thank you. Next. And that's it. Thank you.
Thank you so much, Ruth. And it was really interesting to see how Kenya really secured buy-in at decentralized levels of healthcare in order to advance the process. So really exciting to see all that has happened and is happening in Kenya. And please put your questions in the Q&A for Ruth. We will certainly address them at the end of all the presentations. And next, I'd like to welcome Gertrude Nkube, who is a public health specialist and where she coordinates the HIV prevention program at the Ministry of Health and Child Care in Zimbabwe. She will be presenting on mainstreaming youth-friendly service delivery and delivering oral PrEP and family planning. Oh, I'm sorry, I skipped ahead. I'd like to introduce Fanny Kachale, who is the Director for Reproductive Health Services at the Ministry of Health in Malawi, where she is responsible for overseeing the implementation of reproductive health services for men, women, and young people. And she will be focusing on integrating HIV prevention and reproductive, maternal, newborn, and child health services and adapting lessons from PMTCT in Malawi. And so over to you, Fanny. Thank you so much.
Thank you very much, Jessica. I'll be presenting integrating HIV prevention in Malawi, and I'm doing that on behalf of my colleague, Rose Nyirenda, who is the Director for HIV in Malawi. And we are starting with giving the perspective of 2021 versus 2022 spectrum of the model estimates. Actually, our HIV ART coverage in women since 2011, when we introduced option B+, is high. And we have actually seen that there are fewer new infections among men. As you can see from the graph for 2021, which is in red, and 2020 is in blue. You can see on the side where we are having males 15+, there's that good reduction. But for women, it's slightly higher. Next. And still on the spectrums, for the general population, our prevalence is at 8.5%. But you can see on 15+, where we have actually circled, you will see that for females, the prevalence is higher, 10.4%. Whereas you compare for the same age mates, their counterparts, the males, is at 6.3. So that's why we went into integration so that we target these women as they reduce the prevalence. Next. In Malawi, PMTCT is delivered under maternal and child health platform, and it has considered or embraced the safe motherhood pillars of family planning, where women are accessing modern contraceptives, but also of quality antenatal care, labor and delivery, as well as the postnatal. We actually saw that PMTCT is better, is better practiced under integration in the MCH. Next slide, please. And the opportunities that we saw in MNH is that already in Malawi, there's high antenatal care attendance. We are actually over 95% in terms of antenatal care attendance. Also, in terms of hospital delivery, we are at 93%. So women are already coming. That's why we would want to provide the integration in those areas. Also, in terms of our postnatal services, family planning and cervical cancer screening services gives us that opportunity to integrate, as well as we also have a high expanded program on immunization. Next slide. So the way that we have done our integration in terms of testing services, they are done in family planning, at antenatal, labor and delivery, or when youths actually come to access services. So those testing services are provided there. There's also DNA PCR testing, which is done straight in the MCH and EPI, as well as syphilis screening and treatment All that is being done under that one roof of maternal, newborn, and child health. Whereas once they are at the MNCH, they are already started on ART initiation and continuation. So we are testing and treating. Also, they have that opportunity of having a viral load screening. Whereas if it is in the ART clinic, a woman who goes there is able also to access her family planning services, as well as she can be screened for cervical cancer. Next slide. This slide is just showing us the indicators for January to June 2021. And we can actually just pick a few. In terms of PMTCT, percentage of pregnant women who know their HIV status rating, we are actually showing that much as we wanted them to be 97%, we have been able to reach 98%. And I'll also pick the one for percentage of HIV positive women who received ART during pregnancy, labor, and delivery. Our target was 95%, but we have already surpassed that. 100% of the women are able to receive ART during pregnancy, labor, and delivery. Next slide, please. We have learned lessons in terms of integration. There is high coverage of HIV services among pregnant women, and the integration that we have done has fostered the development of sexual and reproductive health and rights and HIV policy guidelines. We have actually seen also that it has been catalytic to improve other sexual and reproductive health indicators. And mostly, we have improved and increased utilization of sexual and reproductive health and rights and HIV services. Previously, we used to have days where clients would come, let's say for ART, the next day they would come maybe for antenatal care services, and the other day they would come for family planning. And that time, people used to know if you are coming on a Tuesday, you are coming for ARTs. So there was stigmatization. But then with integration, we have reduced the stigma and discrimination, because people would just see clients going to the health facility. They wouldn't know what the client is coming for. Also, we have seen that collaboration and coordination has been enhanced in terms of planning, budgeting, and implementation. We've actually seen that we've been able to reduce program resources gap, like using the Global Fund. We've been able to acquire equipment, which has been procured for us. And we have also been able to advance the areas of adolescent girls and young women using the resources from Global Fund. We have also harmonized the approach on interventions through integration of SRH and HIV. And that has all led to health systems strengthening in terms of infrastructure, laboratory equipment, and logistics and supplies that we've been able to procure using the Global Fund. But also there's been capacity building and competency of healthcare workers through value clarification and attitude transformation approach, where health workers have been able to self-inspect their values, their attitude, and then to actually apply that attitude to a service so that we improve the service. Next slide. It hasn't been all sweet. There have been challenges in terms of integration of M&E tools. You see that HIV is a department on its own, as well as the reproductive health is a department on its own. Of course, we are using that one integrated register, but for us to integrate all the tools, because each program would want several indicators incorporated, that has been the challenge that we have faced. Also, there are high costs in terms of capacity building, where we want the health workers or the providers to have comprehensive skills. Also, there is limited funding, especially for other sexual and reproductive health and rights interventions, as well as the infrastructure that we have is not tailored for service integration. Some of the facilities were built some time back, so we just have to renovate so that that infrastructure is suiting integration. You may need bigger space. Those are things that we have seen. Next slide. In terms of moving forward, we are delivering pre-exposure prophylaxis services within sexually transmitted infections, family planning, ANC, and child health services. We started with 84 facilities, but we have over 750 facilities. So we are moving towards scaling up so that we reach out with PrEP to all the facilities, especially that we would want people to access services closer to where they are. Also, we would want to consider the comprehensive skills set trainings for our service providers, plus the values clarification, attitude transformative approach. Also, we are working on integrated M&E tools so that we target the key variables to be included. And integrated HIV SRH service delivery would want now to take it to community level, having seen that it is working at the facility. Next slide. In conclusion, integrating HIV prevention in MNCH is possible, and sexual and reproductive health and rights and HIV integration has multiple benefits, as we have seen, to both the clients as well as the health providers. And opportunity to increase coverage in HIV services with an aim of achieving UHC, universal health coverage, where we are saying leaving no one behind and improving universal health access to services. Thank you very much.
Thank you, Fanny. And now we will turn to Gertrude Nkube, who coordinates HIV prevention within the Ministry of Health and Childcare in Zimbabwe. Over to you, Gertrude. Gertrude, if you're speaking, we're having a little difficulty hearing you.
Okay, good morning, good afternoon, everyone. Thank you so much, Jessica. I'm going to present on mainstreaming youth-friendly service delivery and delivering of oral PrEP in family planning clinics in Zimbabwe. And this is actually presenting the findings which we did on the rapid assessment to look at HIV and SRH integration within our public health institutions, as well as in our private institutions, which are actually supported by partners. Next slide. So my presentation outline will be looking at the rationale for mainstreaming services, policy environment, integration by facility, and then the champions, what came out as part of the recommendations from the assessment which we did, and the feedback from the adolescent girls and young women themselves, as they were our key informant when we were doing the interviews. Next slide. As a country, looking at the data which we have got from Family Planning Report 2020, as well as our demographic health survey for 2015 in Zimbabwe, adolescent and young people make up about 48% of all new HIV infections. And looking at those new infections, adolescent girls and young women make up about 35% of those new infections. Looking at the unmet need for family planning amongst the 15 to 19 years is about 40%, and comparing to 17% for those aged 20 to 24 years. And on the family planning delivery methods, delivery service points, as you can see from the graph, mainly is actually coming from the public sector. And when it's coming from the public sector, hence the need actually to integrate, foster integration of services, looking at HIV and reproductive health services. And again, as a country, we are actually providing most of the modern contraceptives method mix, as you can see pill is our number one, which is actually most young women or the general population of women actually prefer the pills, seconded by the implants, where we are actually using the Jatel, and then the other methods as well, as you can see from the pie chart. Next slide. However, looking at the policy environment which fosters HIV and SRH integration, we reviewed the documents which were available, which are fostering HIV SRH integration. We have the National Health Strategy for Zimbabwe, which expired last year, but I'm happy to say the new health strategy, which has actually come up, is actually emphasizing more on the integration of services, and is actually guided by the universal coverage strategies, the global universal coverage strategies. We will be launching this new strategy very soon, and it's actually looking at that. And looking at the national health strategy as well for HIV, it expired last year, but as a country, we were able actually to come up with a health sector HIV strategy, which is actually encompassing the issues of integration. Before, our strategies were siloed, like you have the PMTCT strategy, you have the HTS strategy, you have the ART strategy. But now our strategy is actually a combined strategy, and it's outlining issues of integration with SRH. And the Zimbabwe Family Planning Strategy as well is available, looking at integration as well of services, as well as the National Adolescent and Youth Sexual Reproductive Health Strategy. However, the existing strategies, because our main focus was pre-exposure prophylaxis, they actually lacked specifics on the pre-exposure prophylaxis. But like I've already said, there are these other new strategies which have even actually put pre-exposure prophylaxis as part of HIV prevention and how it's supposed actually to be delivered. And the old strategy, they actually lacked even the operationalization, which I think all of us, we always talk about integration and integration, which is in a document, but we are actually looking as a country in Zimbabwe and saying, how best can we put it so that it's actually operationalized? What documents do we need to operationalize these strategies? And at national level, we've got the technical working group, we've got the partnership forum meetings where we meet with different reproductive health, HIV, and Zimbabwe National Family Planning to discuss about this. But what is needed now going forward is actually to cascade from national level so that even at sub-national level, these technical working groups are functional. Although in the strategies they are there, but like I've said, issues of operationalization, they are very important. Next slide. So during the assessment findings on the service delivery, we actually looked at our health facilities, the primary health facilities, which are our rural health facilities. We actually found that integration is there in a supermarket approach, and all services are provided by one service provider in the same room. But what was lacking, which we need to foster going forward, is the issue of these service providers to be actually youth-friendly as well. At secondary and tertiary institutions, which are high-volume sites, we realize that there can be internal referrals, and at times we are using what we call navigators or what we call champions in some of the sites where they are there, who were actually making referrals to both family planning services. As in most of our health facilities, we have what we call FCH services, where we provide FCH program services as well as family planning services. So we realized that there was actually inter-referral, but this one needed actually strengthening as well. And looking at PrEP specifically, we realized in some of these health facilities, we were actually referring clients who needed PrEP to the OI clinics. And we have actually heard from the adolescent girls and young women that this is actually creating a lot of stigma when they actually need PrEP, and then they are referred to the OI clinics. And then we had standalone youth-friendly services, which were supported by our partners like ZNFPC, our Zimbabwe National Family Planning Council. Here's actually youth-friendly services. We realized this one supermarket approach offers fully integrated services for adolescent girls and young women, same provider, same room at times as well within that service delivery, which is actually was a plus on that. But we realized we needed to intensify on issues of HIV, especially within the family planning clinics, where we'll be providing even issues like HIV self-testing. And we realized in one of the pilot sites, which were actually integrating family planning and HIV self-testing, where we're actually saying, while the clients are waiting there, we can give them health education and talk about HIV self-testing. And those who need HIV self-test kits, they will actually get them. And when they are now going for the consultation, already that person will actually be knowing the HIV status. We are piloting it in 4 sites, but we are actually looking at how best we can scale it up, all those things. Private sector depends on levels of facilities, mirrors levels described above, but we actually found that they are able, the adolescent girls and young people, they will prefer that, but the issue of user fee was actually a barrier for them to get those integrated services in those areas. So we identified that there is need to train our service providers. We need actually to build stronger linkage systems that follow clear service pathway for clients. And across sites, provider capacity and youth-friendly services are highly dependent on implementing partner. What we have realized as a country, at times we get a partner who will say, I'm funding this, but I'm not funding this. This is actually deterring issues of integration. Next slide. And then I'm just, what we found as well between the standalone sites and the Ministry of Health, public sector sites, where we need to mainstream HIV, where we need to mainstream reproductive health and family planning services, as well as looking at pre-exposure prophylaxis. So we realize standalone sites, they are actually well-staffed. It's a model which really all the youth sort of like prefer, but too expensive for the widespread scale-up and peer support for PrEP, highly effective. It's ideal, like I've already said, for PrEP, ART would be provided in-house. And we have such kind of examples in the country, especially I've already alluded to the ZNFPC sites, where we need maybe just strengthened by putting HIV, more of HIV services in those areas. We have sites which are supported, like the SHAS hub for adolescent girls in one of our cities, which is supported by Tangia and all that, where they are actually saying they are happy. This is why the adolescent girls and young women. But as a country, looking at what we are right now on our economy, it's sort of like a very expensive model too. We are actually looking at saying that it's actually feasible to mainstream this within our public health institution. This model is less expensive than the standalone, and but capacity is limited. So we need to look at the capacity. Next slide, I've got 1 minute left. Next slide. So what was part of the recommendations from the adolescent girls to say, seeing within the public health institutions, there is limited staff, we need actually to come up with champions. And these are the people who are trained in specific service delivery and can be utilized to promote integration. So they came up with the recommendation at policy level, we need to have standardized guidelines which are actually user-friendly, and they describe on the how part of it to actually how to operationalize that. And then even at Ministry of Health coordinators, we need to plan together with these adolescent girls and young women so that, and even when we are doing the support and supervisory visits, they need to be included. At facility level, we need to promote integration. Let's have meetings and discuss with all of them. at community level, we need the PrEP champions who are a link between the health facility as well as the community. And before these people come for PrEP, already they will be given education by these champions at community level. Next slide, I'm almost done. Next slide. So what else did the adolescents talk about? They said we must look at them as equals. What is it that they want? They need choice, access, respect, and privacy. On the choice, they need integrated and differentiated services of care. And maybe looking at even at the court of that adolescent who said on the choice, at the end, it has to be about choices so that the adolescent is able to access what works best for them. And looking at the privacy as well, I prefer somewhere private so that one can guess what service, one cannot guess what service I'm there for, unlike at regular health clinics where one can tell that you are now going for HIV testing, which means you are having unprotected sex. So when we are actually designing these integrated services, we need to look at what the adolescents are looking at. Last slide, please. So in conclusion, I say mainstreaming of services is feasible. We have already been doing it, but we need to be sort of like a bit organized, a little bit. Let's look at an environment, policy environment supported by operational guidance. Like I actually said, the operationalization of these policies which you are coming up with, they need to be articulated properly, either in a job aid flow chart, so that the people at health facility level, they know if there's an adolescent girl coming in front of them, what services do these adolescent girls need? Capacity building for health facilities. And I think the other most important thing, coordination of investment across different programs, like I've already alluded to, already the barriers, and then engagement and coordination across stakeholders, and not leaving the adolescent girls and young women behind on whatever we are discussing. Thank you so much. My last slide is just to say thank you for listening. Thank you.
Thank you so much, Gertrude, for sharing the insights from Zimbabwe. And I don't want to waste the precious time that we have. We have about 10 minutes, 15 minutes for discussion and questions. And I'd like to just briefly welcome our panelists and our moderator. Our moderator is Anna Miti, who works at the Humanitarian Information Facilitation Center in Zimbabwe. She is an HIV advocate with a background in broadcast journalism. I'd also like to welcome Jacqueline Wambui, who is the Global CAB Facilitator at the Afro-CAB Treatment Access Partnership. She is an activist living with HIV and has a special history and interest in the rights of people living with HIV and advocating on their behalf. So we're so glad she could join us today. And lastly, I'd like to also welcome Barbara Nkube, who is a program coordinator at PZAD and was a key member of the team that conducted the assessments in Zimbabwe. So welcome to all of you. And now we will open the floor for questions, for discussion. So please type them in the chat and I'll hand the mic to you, Anna.
Thank you very much, Jessica. And again, I thank you for that reminder to put questions on the chat platform. I see that there were others that had already been put there. I think let's just start with those, and then we'll turn to Jackie and Barbara as well to give us their perspectives from the CSO perspective. The first one is from Carissa, who wants to know, and I think this can go to any of the panelists that presented here, about if providers need specific incentives to integrate, and what is the basis of their willingness to expand on the scope of what they do. I see there's been answers from Lee and Rose Nyirenda. Perhaps in case people are not seeing that chat, just to answer that, let me call upon Dr. Kachale.
Thank you very much, Anna. We don't need any incentives for providers. Like in Malawi, initially the providers thought by integrating we meant extra work, but later on liked integrating because they saw that they were able to attend to clients on that specific day without moving them to other rooms to get services. So with time, providers liked the integration. We didn't give them any incentives over.
All right, thank you for that response. This one is coming from Lee, who says great presentations and work in integrating services in ANC settings and PMTCT. Lee is curious about research looking at integration or provision in postpartum family planning services. And I think for this one, maybe Gertrude, would you like to come in? Yeah, since you like you're also talking about PrEP.
So, sorry, my network went a little bit down. Anna, can you mind?
All right. Lee is curious about any research looking at integrating oral PrEP provision in postpartum family planning services.
Oh, okay. Maybe as a country, we haven't actually done any research on that one, but what we've done, we have actually looked at WHO guidance. As you know, WHO guidance has actually said we can actually provide PrEP for pregnant and lactating women. What is actually happening right now as a country, we have actually come up with a new operational plan for pre-exposure prophylaxis. We've included the pregnant, and we've even quantified for the pregnant women to be getting oral pre-exposure prophylaxis. And these will actually be given within the ANCs, within the FCH as well, as I've alluded to. We are trying to move away from actually providing PrEP within OI clinics. Thank you.
Right. We have a question from Lucy who says, thank you so much for the inspiring presentations. And she says that we are at last coming back to the world of good old STI and HIV prevention in SRH. However, she's curious about providing access to integrated services for key populations and mobile populations, even those who are cross borders. And I think any one of our panelists can answer this one. Would like to take it up.
Thanks, Anna. I think I'll jump in at this point. I think integration is key for key populations because accessing services has already been a barrier through the conventional means. So finding ways in which we can integrate services and provide all the things that they need in one place in safe spaces becomes essential. So yes, we should be thinking about key populations in that sense. That they should be able to access anything that they need in an approach that meets their needs specifically. So differentiated, integrated services.
Mm-hmm. And since I have you, Barbara, let's look at partners in terms of implementation for the different ministries of health in all these different countries. PSAT is an implementing partner. How important are these in ensuring that we have integration of family planning and SRH services?
So partners play an important role because we've got an opportunity to be flexible, to try new things. We've got contact with communities. So we get the chance to try out things, to demonstrate effect and necessity of integration, and then take this up to our ministries. We plug in through the technical working group. I must highlight that it's important though for us to include our governments from the onset, right from the planning stage, the implementation, upraising them on the data collection itself, so that we go through this together. And it's not implementing partners coming with suggestions from the outside, but it's something that becomes ingrown or coming from the inside together and easily acceptable and easily adapted.
Right. And Jackie also represents civil society. Can you tell us about what role you think civil society plays in maybe promoting integration of services?
Hi, Anna, nice to see you. As I say hello to you, I hope my audio is clear.
Yeah, it is.
Okay, great. Okay, great. So thanks for having me. So what I'd say, the role of civil society is, I just pick up from what Barbara has said, is just seek for inclusion in all these conversations, like what we did in Kenya even before we became before civil society was even invited to become part of this integration committee, right after or even before the ECHO trial, a task force was formed, which included both the HIV and SRH offices in government, but included also civil society, just to pave way for the results of the ECHO trial. And what civil society did was actually prepare women for these results. And of course, now after the results came, now is when now civil society now started demanding for now the start of integration services, because it was clear from the trial that this was not happening and this is what women needed. So the role is actually to ask for inclusion and be part of the way, which has been happening, as now Ruth mentioned. We have been part of that committee and it has worked very well, because you see how the government has been working, trying to set this up. And of course now, as a civil society, making communities create demand for these integration services. Yeah.
Right, thank you very much, Jackie. On our Q&A segment, we have Martha Brady, who's saying excellent presentations and lots of great insights. Thanks for that. She wants to know if any of the speakers can address issues of product or commodity availability at the same time. When you're looking at integration, things like the PrEP and other family planning products.
Anna. Yes.
Yes.
On the issues of commodity, maybe I'll give an example for Zimbabwe. In Zimbabwe, we have got what we call forecasting and quantification, which we do every twice a year. And we have actually, we provide our targets, we work together with our logistics, and we actually provide the issues of the commodity supply chain. And in that commodity and supply chain, it's not only for HIV, but even for family planning commodities, including the contraceptives and the condoms. And mainly our funding is actually coming from the Global Fund. So when we do that, it's a way of even mobilizing resources to look at how many people want to put on PrEP and all that. And we've included all that in for our commodity and supply chain. Thank you.
All right, thank you so much for that clarification. Perhaps at this point, I'll hand back to Sarah, as we're seeing that we have 2 minutes just before we get to the top of the hour. Sarah, I'll give you the floor.
Thanks so much, Anna. Hi, everyone. I'm Sarah Allender from the Georgetown University Center for Innovation and Global Health. I want to thank all of our presenters today for their presentations, as well as all of their colleagues in Malawi, Kenya, and Zimbabwe who assisted in putting together the presentations and the research. We've learned a lot today from our presenters about the experience in their countries. And I just want to highlight 3 overarching takeaways as we end our session. One is the need to reduce the gap between policy and implementation, and ensure that policies are updated for PrEP and in its current form, in the oral form, as well as in preparation for the vaginal ring and for the injectable PrEP that will be coming online shortly. Second, given the dependence on implementing partner or donor funding and their programmatic priorities and how those affect national programs as well as individual facilities, there's also a charge for funders to de-silo their funding and their programmatic priorities and support these integrative approaches and begin to coordinate investments further to be able to facilitate that integration at the facility and community level. And third, we've heard today a bit about data and the need to create integrated monitoring and evaluation tools that ensure there's sufficient data for integrated service provision that can inform decision-making and help with better targeting and delivering of services for adolescent girls and young women. And just a final parting reminder that we now live, thankfully, in the golden age of HIV prevention products with a toolbox that we've never had before. And we have important knowledge and learning from a number of settings that can help us provide these products in a supportive, stigma-free environment. And that's something that we all can take a collective responsibility for helping to achieve. So thank you all for your participation today and for joining us, and look forward to seeing you on a future webinar.
Thank you. Thank you all. Thanks.
Thank you. Bye.
Bye.